Yeah, thanks a lot. Also, thanks to the organizers for having invited me, and thank you for the introduction. I'm currently located in London, and I have previously worked for 20 years at the NKI, where I still have an affiliation with. These are my disclosures. My talk is basically focusing on the surgical aspects of operating on VHL-related kidney cancers. However, I would like to make sure right from the start, I'm not talking so much about the surgical details because they are not that much different for patients who have non-VHL-related kidney cancers, but more what the general paradigms of management are. And to this effect, I brought up this first slide. It was published, it's based on a publication that is 15 years old. The first author is a fellow at the NCI in Washington. And interestingly, these conclusions of the publication have not changed until now. So basically, nephron-sparing surgery should always be undertaken whenever it's technically feasible with the goal of removing all tumors in that renal unit. And the role of minimally invasive technology is currently being evaluated in selected patients, and this is ongoing. It is very interesting, though, to look a bit into the history of this development. So in the early 1990s, late 1980s, there was resistance to this previous paradigm of bilateral nephrectomy, followed by renal replacement therapy or dialysis. And you can see that as early as 1992, 1995, there were a small series of patients who underwent what we call a partial nephrectomy or nephron-sparing surgery. And these series got bigger, but they were mainly performed at one site that gained most of the experience. So most of the paradigms that have been developed at the NCI surgery branch Bethesda in Washington. And of course, these were retrospective series. They have a wealth of information, and they have been published in the Journal of Urology as early as 2004. So as we all know, there's this 3 centimeter threshold rule that says that you shouldn't jump to on the smallest tumor that is already visible, but you should wait. And this idea comes from the knowledge that many of these tumors recur. So you don't want to traumatize the surgical fields early on. And with this paper, in a larger number of patients, they could show that there is no risk or harm involved if you wait up to 3 centimeters. Then in 2008, they showed that repeat partial nephrectomy is feasible. That comes as a price. It has about 20% major complications and a slight drop in renal function. Later on, they also showed that this is feasible in solitary kidneys. This is very important. So if you had undergone surgery and your kidney, the contralateral kidney was already removed, then this is very important information for patients. And finally, they were able to show that what they call multiplex partial nephrectomies were feasible of at least 20 tumors in a solitary kidney. So that means that once you go in, you try to remove as many tumors as possible so that you disrupt further growth of these tumors. Interestingly, in parallel, there was a study that's the only randomized controlled study we have. It has its own flaws, was set up to investigate whether this partial removal of tumors, or let's say a partial nephrectomy, is as good as a total nephrectomy. And the study published in 2010 and confirmed that. Looking into larger tumor sizes, so CT1B and T2, we have to do with systematic reviews. Systematic reviews are a bit the poor man's phase 3 trial. So they basically look at data that have been published. The biggest downside in most urological or surgical series is that most of these series are retrospective and they have their own bias, so you increase the bias. But nevertheless, the body of evidence we have from these systematic reviews suggests that there is an acceptable surgical morbidity, equivalent cancer control, and better preservation of renal function if you preserve the kidney and just remove these larger tumors. When we communicate as surgeons, I think it's very important that we use a sort of vocabulary that leads to understanding of what we actually do. So we make use of these nephrometry scores. This is the renal score, which I brought up. There are other scores. Whatever They have been validated to a certain extent, but Renal and Padua are most commonly used. What it basically means is that you can imagine you have a small renal mass, let's say it's 3 centimeters in size. If this small renal mass is located in the interpolar line and fairly deep in the kidney, then it is much more difficult to operate on than if this is dangling off the lower pole and can be excised even without clamping the artery. So these are important informations also when you want to compare outcome of surgical series. The other thing that we make use of in the last years are 3D planning softwares. Some of these publications are as old as 3 years, 4 years. Some use printed models. We make use of a virtual 3D model that appears on the screen and that you can flip around. You can also have that on your iPhone. This is a non-VHL kidney cancer in a very complex situation. You recognize here as a horseshoe kidney. This patient earlier underwent an open infra-renal aortic prosthesis for an aneurysm. So as that was really stuck, we needed to have as much information as possible about the location of the tumor and the feeding arteries. And you can imagine that these situations also occur in VHL patients. And these models and tools really help you to perform the surgery more accurate. This is a busy slide, but I just want to bring it up to debunk or confirm a couple of myths around nephron-sparing surgery. I think as patients, it's very important to know that basically this procedure leads to the same oncological outcomes, whether you do it open, laparoscopic, or robot-assisted laparoscopic, whether you do it trans or retroperitoneal. None of these techniques has ever been compared in a prospective fashion. All we know from systematic reviews is that if you go for minimal invasive surgery, then it seems to be that there's less blood loss, a shorter length of stay, and less major complications. The next topic that is very often and frequently discussed is how wide shall we excite these tumors? Should we leave a parenchymal margin, or can we do an inoculation? And again, here only retrospective data. Systematic reviews of these retrospective data suggest that there's better functional recovery when a tumor inoculation is done at comparable oncological outcomes. And lastly, there's much discussion about ischemia time, the duration of ischemia time, whether it should be warm, cold, or zero. And interestingly, when you compare these series, there doesn't seem to be a superior technique over the other one. Regarding the duration of ischemia time, I think we can all imagine if it takes too long, then it will be final. But whether it has to be hyperthermic or warm, it's really hard to say. And interestingly, an additional time of 10 minutes of warm ischemia seems to lead to only a 2.5% decline in recovery from ischemia. I think what we can summarize is that there is no clear cutoff, how long you can shut off the kidney from its blood supply. It is also depending on the gestalt of the patient, so whether you have pre-existing diabetes, for example, or kidney failure. Then moving into some publications, again, I don't want to go too much into detail. I'll just bring this up here. That's from 2008, so 12 years ago. The majority of patients who would undergo partial nephrectomy would still undergo this open, so 60% in this series here. And it also came to light in other publications that when we were looking at the probability for these tumors to recur and patients to undergo second surgery, then this is actually quite high. So it is up to 1/5 of the patients have to undergo a second surgery within 5 years, and roughly 50% if you look at the 10 years period. So it doesn't come as a surprise that we would be looking into methods that allow us to do this less traumatized. And that is obviously one of the tools here is the robot. The robot has really revolutionized partial nephrectomy. I think for most of us, even if you go through a long trajectory of surgical training, a laparoscopic, so with a single lens and just fixed instruments, performed laparoscopic partial nephrectomy is an onslaught on your cerebellum. You really need to be skilled to do that. And it's much easier with the robot owing to the fact that the robot has 2 lenses, so you can actually calculate the depth of vision. And the instruments have a wrist and endowrist, and you can work quickly and very carefully in confined spaces. The techniques have been mastered, and they have been published, and the reconstruction is nowadays very safe. So I think in most hands, a partial nephrectomy can now be done, depending on the complexity, in between 17 to 15 minutes warm ischemia time. And this brings us back to the initial idea. Again, here we have series that are published from the NCI. They now repeat the series that they've done open with the same questions asking, for example, is multiplex robotic partial nephrectomy feasible? And you can show in this graph here that when they started in 2009, they would only take on few of these lesions, and then the number of lesions excised would increase, and the conversion rate to an open nephrectomy also went down. And that is quite interesting. And the mean number of tumors removed is about 9. And again, this shows that it is very good to be treated in centers of experience. This is a very nice example of this learning curve here. What they also showed is that repeat robotic partial nephrectomy is feasible. So if a patient has undergone robotic surgery before, you can actually do that twice. It leads to slightly estimated more blood loss. There's a post-surgical length of stay is prolonged, and the frequency of urinary leak was significantly higher, but the outcome in terms of oncology and renal function are very much comparable. This is a patient from the experience we had here in London. It is an obese patient who had undergone previous surgery and had a prolapse through the abdominal wall with liver prolapsing. And it was unattractive to go in there with an open technique. And we therefore decided to give, based on the experience we have, to approach this robotically. And during the surgery, it was found that the liver actually, that there was a lining of peritoneum in this herniation, that the liver slid out, and it was actually very easy to perform. That is bringing us to this other topic: how many tumors should be removed? What is safe? Again, here, a large series from the NCI that was looking at solitary kidneys. Is it safe to remove more than 3 of these tumors, or should we stay put, just take the bigger one and then observe the others? And they found that there was no difference in terms of postoperative complication, renal function, and completion nephrectomy rates. This is another example of a patient we had operated in London. I bring this up because, first of all, it was a redo after a previous open partial nephrectomy, but also it shows the difficulty of performing these surgeries when there are many cystic lesions. And there are 2 schools. One of the schools says, well, you can pop these lesions. Others say you should be a bit more careful. If you look at a recent publication here in Oncology Letters from 2019, there's a pathological study that shows that in some of these cyst linings, you find renal cell carcinoma cell clusters. On the other hand, most of these renal cell carcinomas are of low malignant potential, and you may as well sit and observe them. Very quickly, because this is also very often discussed in multidisciplinary team discussions, what should you do when there is a bilateral presentation and it needs to be done bilaterally? This is my personal opinion. I think a 2-staged approach is preferred, simply because if there is a postoperative problem, it might affect the other kidney you just did surgery on. And I prefer to take the less complex side first, because I like to have a successful nephron-sparing surgery behind me, so that I know that I can estimate the residual function in case of a contralateral nephrectomy. Others may argue just the other way around, and they say, well, I like to take the difficult case on first, and I know where I'm at. But there is always the risk of losing a kidney if you do nephron-sparing surgery. So it might be very good to be safe here. Very briefly, alternatives. This is a talk about surgery, but I would like to point out that ablation is coming of age. We do have series published that look at large numbers of patients. Most of them are, again, analyzed in systematic reviews. There's currently no trial ongoing, or has reported there's one ongoing, but there's no results from whether ablation is as good as partial nephrectomy. But the results suggest that this is oncologically safe, and leads to a lower complication rate than partial nephrectomy and better preservation of renal function. And there are already some series published where cryoablation was performed after a previous partial nephrectomy, because this seems to be more attractive than risking going in there again and having surgical complications. This is again a non-VHL overview of these patients, a large series from the Mayo Clinic of 1,800 patients undergoing 2 different types of ablation and partial nephrectomy. The issue is, if you look at overall survival is always poorer in ablation series, and that is simply because old and frail patients were the preferred population. But if you look at metastasis-free survival as a surrogate for tumor activity and aggressiveness, then you can actually see that the outcome is very, very similar here. And I would like to conclude. I think or hope I have made sure that the right surgical approach is multiplex partial nephrectomy if feasible, and tumor enucleation after one of the lesions reach the 3 centimeter threshold. Then that triggers your indication for intervention. And this has evolved as the current standard of care of nephron-sparing VHL surgery. Importantly, tumor size is no limitation for nephron-sparing surgery, but the complexity is, and that should govern the approach. I think it is also important to consider that because 20% of the patients require repeat intervention within 5 years, it is important to consider early on minimizing surgical trauma with a preference for robot-assisted laparoscopic approaches. Repeat partial nephrectomies should be performed in experienced centers where these procedures yield very good functional and oncological results following various previous approaches, including ablation. We had a couple of patients where this was successful. And thermal ablation is evolving as an alternative strategy, and I think this will be very important to observe this field. Well, thank you very much for your information, and I'm happy to take some questions if we do have them.